Many of our patients have never used a computer, and some can't read beyond a 6th grade level. But despite those challenges, our patients are thriving. Preliminary results show that the majority of patients have already met or exceeded the goals set for the end of the year-long study. With the exception of one patient, no one has been hospitalized or sent to the ER because of their diabetes since entering the program. But let me be clear, this connectivity between the providers and the patients would not exist but for the Universal Service Fund support that this region enjoys. This is true for many parts of our state where we serve, and it is critical for our continued success. As we look to expand this pilot, our biggest concern is the ability to connect with patients in their homes and communities. Despite our needs remain the same, increased reimbursement parity and continued access to reliable, high-quality connectivity. Given the jurisdiction of this committee, I urge you to consider 3 issues: the need for continued support of universal service funds, the need for broader application of the FCC E-rate program so that we can use telehealth services in the schools and take advantage of the E-rate program, and then the need for a more inclusive Healthcare Connect Fund. As a large hospital, we don't enjoy the pleasures of the full benefits of that program. So I thank the committee for the opportunity to testify, and I'm happy to answer any of your questions that you may have. Thank you.
In your testimony, Dr. Henderson, you expressed concern regarding future availability of universal service support. So what would happen to programs like the one in Sunflower County, which Mr. Gibbons has visited, if competitive wireless coverage is reduced in that community? And are you able to do what you're doing today without robust wireless coverage there?
So simply put, we wouldn't be able to do it, bottom line. That program depends on a robust telecommunication network and is dependent upon the wireless connectivity. And as we advance that and scale it up across our state, we've got to have that infrastructure or it simply will not happen. We won't be able to reach people where they are. They'll have to drive to go get health care. So just a quick visual, every green and red dot on this map is taking advantage of USF funding in Mississippi. So without it, we would not have a robust telehealth program.
Okay, so we'll put that in the record. So, Senator Manchin.
Thank you, Mr. Chairman. Thank you all, too. And I would like to start out with something about substance abuse treatment to see what you think about this. And 2.1 million Americans are addicted to prescription opiates. An estimated 6.5 million Americans currently abuse some sort of prescription drugs. In my state of West Virginia, it's the #1 killer. Comes out of the medicine cabinet. No one seems to be talking about it. It almost seems, and everybody in this room right now knows someone in their family, immediate family or extended family, that's been affected. It's an epidemic proportion. We're not talking about it. It's almost as if we accepted it. It is what it is. What are we going to do? And I think we have to do something because it's destroying a whole generation and the family structure as we know it. Do you believe prescription drug abuse is one of the biggest medical threats we face today? And what role do you think that telehealth can play in leveraging our limited resources to combat it? Anybody on the, if you want to speak up on this. Dr. Henderson.
So I'll take that. So I think it's interesting. Absolutely, I agree with you. It's a huge epidemic in our country. And the technology allows us to use the services that we have and scale them up and reach people where they are. And so that's in-home, that's virtual support groups, that's counseling, that's day in and day out support. It's almost AA in a mobile platform. But there's so many things that we can do, and from counseling and support groups, that the technology allows to do it more often and more frequently where the patient wants it, and can support people through that transition off of the drugs. Not to mention help with oversight to be able to see and monitor who's prescribing what with shared electronic medical records.
Well, there's two things, I think. I mean, basically, you have to produce the drug first, and the FDA is letting stuff come on the market that shouldn't be on the market, and we're going to, I think, want to rein that in. Second is how they're prescribing it.
Right.
Doctors were handing out like candy. And we've changed that from Schedule 3 to Schedule 2 in opiates. There's so much more needs to be done as far as in them, and also following up on them to make sure they have continuing education of what they're doing to people.
Absolutely. I think that what's interesting now is that before we didn't know what the other health systems or other providers were prescribing. You took care of a patient right then in that instance. Now with the shared electronic medical record, we can know more and be able to make smarter decisions.
When I was governor, I always felt that if we could connect, if anybody was providing for Medicaid and also Medicare, should be connected, real time. We have people shopping, and especially for the opiates. They'll go on Friday nights, they start their shopping, you understand, because that way they know limited staff. They'll go back pain, 6 pills, back pain, 6 pills, 4 or 5 hospitals a night. And before you know the weekend, they got a pretty good stash. They're ready to go start selling on Monday. This is how we followed it all the way through. But we didn't have any doctors with real time. Says, wait a minute, Dr. Gibbons, you just were down the road here yesterday or this morning. But every time I pushed on that, they would say, well, first of all, they can't afford it. There was no mandate from the federal government to saying if you're going to participate in Medicare, Medicaid, which is the largest part of reimbursement, this is what you had to do. And they said privacy. Then I had the privacy thing and I had the cost. Are we making any grounds at all on getting people connected? I mean, anybody want to take that one?
I will. We are in Mississippi, and it's working, and we're saving money. We're addressing it. We're reaching the most.
You're connecting
underserved
real
areas.
time, so I can basically, if I walk in with my card and I'm Medicaid recipient, you can check and say, hey, Joe, you just.
In 166 locations, we're doing that. Now it's more of a plug and play. It's not UMC's, our health systems network. It's now anybody that is a provider in our state can get on the network and take care of patients.
Because you do have some say in the Medicaid. You don't have any say in the Medicare, but you have say in, so in Medicaid, you're doing this.
Third-party payers, that's right.
Okay, I'd like to check on that more. Thank you.
I just met, in fact, last week with the winner of the Principal of the Year of Montana, and we chatted, and I asked, what are some of your challenges as a principal? You know what her first thing she said to me was? Some of the mental health issues that our children face today. We need more mental health services for our kids in our schools. Even though schools currently have access to broadband services, why do you believe the deployment of telehealth services like mental health counseling in schools have been slow to develop?
Dr. Henderson, were you eager to
On the mental health piece?
Yes.
Absolutely. The challenge is that that's not a site of service that can be reimbursed. So, and we can't take advantage of the E-rate connectivity there. So if we can change that so that we can use that same connectivity to deliver health care and that the school becomes a site of service where we can be reimbursed for that care, then you'll see that jump up.
I'd like you to respond to the critics out there who believe that this will open up the floodgates and perhaps address how you see it not doing that and how it actually brings more efficiency to the system, or however you'd like to respond. Dr. Henderson, if you want to start with that, that would be great.
Yeah, I'd love to. Thank you. So no better way to answer that than with facts in our story in Mississippi. Once we cleared all the barriers to reimbursement and regulations in our state, that was the fear. The floodgates are going to open and, oh my gosh, it's going to cost us more. But in fact, we've seen quite the opposite. So now over 12 years of experience in this, and we're seeing lower cost and improved health outcomes. So there's nothing better than to show those facts and find other states that have had the same type of outcomes and be able to provide that forward for examples. And so we think that if you move those same, advance the legislation at a national level, that we'll see the same benefits and cost savings.
Great. Thank you.
I wonder if I could ask maybe Ms. Henderson, beginning with you, whether your feeling is that telemedicine can be beneficial in treating mental health issues based on your practical experience. Are there ways that Congress can support and expand access to mental health care generally, and particularly for those groups that I've mentioned and others who may not have the access and availability that they really need?
Yeah, absolutely. Thank you for that question. So let me give you another example that is, we started this year. In one of our 4-year colleges in Mississippi, we offer now telepsychiatry services to every single student. So they can have that anonymity and go to the regular clinic on campus that they would go for their cough or cold, and we'll connect to one of our psychiatrists at our facility hundreds of miles away. And it's making a huge difference. And it's about access, and it's about access where they want it, because you're right, people don't want to be labeled or have to go into public and have it obvious that they're going to a mental health clinic. So I think that we can transform the mental health delivery system and offer it in unique ways. One of the challenges and ways that we can be supported is to be able to do this in all levels of schools, going much younger into the elementary schools, and start to deliver mental health services and counseling services and bring in the parents as well as teachers and students. And so we can do it in some transformative ways that our traditional model would never be able to financially support and wouldn't be successful at. So that's one way we could enhance that.
And are people secure in the confidentiality and anonymity of the service that's provided?
Yeah, absolutely. I think that a good way to look at it is this is really no different than in-person care, except that you're stepping into an exam room and getting it through a connectivity in that room. And so the same challenges of privacy and security in an electronic medical record in my clinic, if you physically came there, are no different than if we did telemedicine. So they feel comfortable.
And the more people Skype with relatives, the more comfortable they are with this kind of communication.
That's right. All ages have been open arms with this because it's about access, and it's convenient access that they can take advantage of.
How, and I guess Dr. Henderson, maybe this is the best for you. How do telehealth providers get funding for operational and administrative support?
How do you tell what? I'm sorry, I missed that.
How do telehealth providers get funding for operational and administrative support when they can't use HCF allocations?
Senator, thank you for your question. While the Commission has considered supporting administrative costs in the health care fund program, it ultimately decided against doing so for several reasons. First, exclusion of administrative costs from the program support obviates the need for additional complex application requirements, which would be necessary to protect the support from waste, fraud, and abuse. Accordingly, both USAC and applicants are spared for such additional requirements. Secondly, lack of support for administrative expense has not seemed to hinder the program participation. Thousands of healthcare providers participate annually in the program. And finally, the Commission has designed the healthcare fund program to minimize, to the extent possible, administrative burden on the applicants. And to this end, and among other things in the program, these are the reasons why they've decided not to support administrative costs.
Dr. Henderson, would you like to add anything to that? Or?
Yeah, I would just add that in our state, we have the challenge of being a consortium leader, but having a cap on that. For any large hospital over 400 beds, there's a cap on the funding that you can receive. And the challenge with that is we're the anchor institution that everybody wants to lead the consortium. And so we have challenges with covering our cost with that. And so I would love to have a review of that as a consortium leader in a rural state, leading all these rural institutions, being able to be that funding being opened up.
The issues of covering reimbursements and costs and technology. I mean, we have so many people working on what they think will be the, healthcare delivery into the home, where so much of the vital statistics of a patient can be then transported to their physicians and monitored. And so what do we need to do to make sure that we're getting flexibility in what's being covered in telemedicine?
So I think that any restriction based on geographic location is limiting our vision and impact that we could have for telehealth. I think we're just still scratching the surface on the possibilities here. When you think of what the healthcare team is going to be ultimately made of, right now it's physicians and nurses in a traditional model in a clinic, but when you start thinking about community health advocates and paramedics and all the other people that are part of the team that are working in a different area, now we're going to be able to connect all those. So I think we've got to think really big and try to be as forward-thinking as possible when we're writing these reimbursement legislation to be able to have the full impact.
Dr. Henderson, Minnesota State Legislature is currently debating a bill that would require health insurance to pay for remote consultations the same way they do for in-person visits. And the bill would greatly expand telemedicine and allow for patients in rural and underserved to better manage their health. As you can imagine, in Minnesota, we have the Mayo system. They do a lot of that going back within their own system, which is different, but this would also allow to have insurance companies pay. As you mentioned in your testimony, Mississippi already has a law like this, again, a rural state. Could you talk about what you see as some of the benefits of a law like this?
It will be the catalyst to open up your telehealth program so that you can have the full impact to access and improving health care to lower cost. So when we did that, it was the concern was, of course, it's going to be fraud and abuse and overused and not going to have any improved health care outcomes. But we saw quite the contrary. We saw improvements in health. We didn't see an increase in cost, and access has improved all over our state.
Very good. Thank you.